Good afternoon, everyone. We hope you all had a great lunch and time to get to know each other a bit more. It's time for our next segment, Patient Advocacy Organisations in Action. Here we are showcasing two representatives of organisations that are doing really exciting work. At the end of these two presentations, we will open the floor up to audience questions. So listen well and have your questions ready for a discussion. It is my pleasure to introduce our first speaker, Frances Reid, of the World Ovarian Cancer Coalition, to speak about the Every Woman Study Low and Middle Income Edition and the incredible work they have been doing. Pleasure to have you here, Frances.
Thank you. Thank you very much for the warm welcome. Thank you to IGCS, to IGCAN, and to the Irish Society of Gynecologic Oncology. That's a big word to get through. I'm Frances Reid. I'm Programme Director for the World Ovarian Cancer Coalition and Study Lead for the Every Woman Study. I've nothing to disclose. So in case you don't know who the World Ovarian Cancer Coalition are, we have a vision of a world where every woman living at risk or living with ovarian cancer has the best chance of survival and the best quality of life possible, no matter where they live. We're the only global advocacy organisation focusing on ovarian cancer, and we will drive profound and equitable change for all of those impacted by the disease through partnerships, evidence, advocacy and awareness. We were founded officially in 2016. It grew together from a global community of ovarian cancer patient organisations and advocates around World Ovarian Cancer Day, which takes place each May the 8th. In different countries, you get ovarian cancer awareness months. They're in different months of the year, but this is one day in the world where people come together. And I have to say the Irish team are phenomenal when they do that. We have over 200 patient advocacy organisations. Some are dedicated solely to ovarian cancer, some to gynecological cancers, and others pan-cancer or a more general women's health remit. We work in different ways. So we raise awareness of the disease, both of the need for global action and to raise awareness of the symptoms of disease. And we generate a lot of evidence. And that's what I'm going to talk to you about today. We work collaboratively. So what is the Every Woman Study? Well, it first was developed in 2018. It's a multi-country observational study exploring the experiences of women with ovarian cancer. So listening to what is important to them, what has happened to them. Covers awareness, it covers routes to diagnosis, it covers time to diagnosis, it covers treatments, it covers the impact of treatments, both emotionally, financially, and physically. And it asks women about their priorities as well. And we aim to quantify the challenges and the opportunities to improve diagnosis, treatment, and quality of life. In 2018, we ran it as an online survey. We had 1,531 women from 44 countries take part in 15 languages, and it was a huge survey. It was something like 150 questions, which breaks all the rules about surveys. You'll see from the globe on the right-hand side, countries listed there. They were the participating countries, and the bigger the letters, the more participants we had from those settings. Our results were published in the International Journal of Gynecological Cancer, and they showed a common set of issues. And I hope when I talk about the issues here that they're relevant to those in the room with endometrial, with other types of gynecological cancer. I think there's messages in this for all of us, so I hope you also find it interesting. Common set of issues, but each country has a different mix. So if I talk very briefly, in the UK, we found that women were quite aware about ovarian cancer. They did go and visit their doctor about their symptoms, not necessarily very quickly. Big amount of time between visiting their doctor and actually getting their diagnosis. But then when they got into the system, they were treated and operated on by gynecological oncologists, so specialists working in the field. Contrast that with, say, Germany, where there's a different culture, there certainly was in 2018. If a woman has something wrong with her, she goes to the doctor quickly and expects the doctor to do something about it. And the doctor does something about it quickly. But in Germany, they have a different health system structure, and it's much harder for a woman to end up under a gynecological oncologist. So their issue is different to that that's in the UK, but they do have common problems. There was no country in the study that didn't have significant issues, and that gave us the idea that there is potential to learn from each other. So why did we want to do a low and middle income edition? Basically because 95% of our respondents came from high income countries, and these are as defined by the World Bank. Whereas 70% of women who have ovarian cancer live in low and middle income countries. Okay, where predominantly at the moment cervix and breast cancer are big issues, but ovarian cancer will increasingly become an issue for them. So GloboCan predict worldwide that incidence of ovarian cancer will rise by 50% by 2050 and deaths from ovarian cancer by 70%. It's much less in the high-income countries. In countries in Africa, it's more than doubling in that time frame. So what they don't necessarily recognize as a big issue, it will be a big issue coming down the line. So we felt our data didn't represent the women of the world. So we established an oversight committee. I'm delighted Eva Maria, who was on the platform earlier, is on our oversight committee with clinicians and patient advocates from right around the world. And we looked at how could we make the study more accessible. And the answer came back quite clearly. It needed to be done through hospitals. Now that opens up a whole barrel of bureaucracy. So ethics approvals, things like this take a long time. We were very fortunate to become strategic advocacy partners with the International Gynecological Cancer Society. And together with them and the amazing Dicey Scroggins, of whom you've heard today, she was on our oversight committee as well, looked really hard. We reduced that mammoth set of 159 questions down to 59 questions so that it could be run in clinics. We made sure that women could do it by email. They could do it by a WhatsApp link or a Telegram link for Russian-speaking countries. They could fill in a paper copy in their own language, or they could choose to be interviewed. So it was a great investment in time by the clinical teams. We identified 24 country leads, 22 of whom were successful in getting through the often very difficult process of getting ethics approval for a study like this because it was so new in settings. And I'm scanning around the room. Dr. Aisha Mustafa, who is at the back there, is our Nigerian country lead, who did an amazing job gathering 11 hospitals in Nigeria and submitting data on nearly 200 women into the study. So where did we get to and where are we now? So as I said, 22 countries participated. They're listed here by HDI index. That is actually Human Development Index. So that's a score that takes into account socioeconomic status, health status, and education status of countries. So you'll see there's a widespread. There are an roughly even mix of countries in Latin America, Asia, and Africa taking part. And women who were diagnosed within 5 years of actually taking the survey were allowed to participate as long as they had ovarian cancer, as long as they were 18 on the day that or over on the day that they took the survey, they weren't attending for their hospital diagnosis, and that they were considered well enough physically and mentally to participate in the study. It took us 2 years, but we got we got over 2,500 women, but when we did the data cleaning, we've ended up with data from 2,446 women. And we have been successful in getting our protocol published, which includes all the questions, the methodology, and so on. So it is replicable. Can't say that word. So the strengths of the study are the number of participating countries and women, the diversity of the women, both economically, so, in their own income brackets, you'll see, geographic factors, in the breadth of topics that were covered. And these were issues that often the clinicians hadn't had a chance to discuss with women. And one of the real strong points of the study was a changing relationship between the clinicians and their patients, when they were able to understand more the complexity of how what is going on in a woman's life might affect her route to diagnosis, might affect her choices about treatment, and might affect her psychological well-being. We've built it so that countries involved could have comparative data. So 15 of the 22 countries reached their minimum sample sizes, so that when we get through the final set of analysis, not only will they have a country report of their own that they will own and do work on and work on publishing, but we will be able to provide the context of how they differ between how their country differs between the global set of data and perhaps, say, other countries in their region. It's been a big bonus for the collaborative efforts of all. We had 82 hospitals involved with teams, some of whom had never used our data capture system before, some of whom had never been involved in a collaborative trial before or study before. And there is great potential for multiple outcomes from this. We've already seen some, such as the setting up of patient advocacy groups, say in Malaysia, of new projects, of new research opportunities involving patients. So we hope that the legacy of the study will live on. First of all, though, I want to share with you some of the voices of women. They may not have participated in the study. We weren't able to get through ethics approval for all countries for video interviews, but we've done them since separate as part of the study. And it's time to hear from them for about 5 minutes. Somebody could set the video going.
My name is Stella. I am from Nairobi, Kenya. I am a teacher and I'm married with 4 children. I think the biggest problem is financing the treatment. It's actually very expensive. And for one, many women in my country do not have employment. They are housewives at home. So I want to imagine it's a big problem because even for me, before my insurance came in, I was just wondering because the treatment was taking almost what I earn in a month. But I was lucky because my insurance was chemo sessions and any other tests that I was taking in the labs. I know finances are a big problem for many women, and most of them could be diagnosed when it's too late. Even after they have discovered the problem, because I see the rest of the people who get like breast cancer, most of them do not survive it. They start treatment so late because of raising the funds.
Mi nombre es Laura. En la 55 años, vivo en tiempo. Entonces, para mí no hubo dificultades en cuanto a transporte o a dificultades de acceder a los servicios médicos. Afortunadamente cuento con una póliza parte de afiliación al sistema de salud colombiano. Entonces, pero yo soy un porcentaje muy pequeño de la población. En general, las personas que sufren no solamente este tipo de cáncer, sino de otros, que se encuentran en sitios remotos, alejados, en el país, con dificultad de acceso a los servicios porque no se cuenta con los especialistas, porque no hay los médicos suficientes, o porque no tienen las condiciones de transporte hacia las ciudades, que son las que realmente enfrentan grandes.
Hi, I am MT Gupta. I live in Luxembourg. I'm an Indian. Right now, I'm in India in a city called Bhopal. It's in the center of the country. I am an ovarian cancer patient, high grade serous ovarian cancer, stage 3C. Now, the stigma and the taboo around cancer in India comes from multiple things. One, like I said, it's a fairly new phenomenon in India. And in India, if you don't know about something, the best approach is to keep quiet about it, which means doctors don't talk about it, patients don't want to talk about it, and the family members don't understand it, right? In India, we have a very strong family system. It's, I don't know how many of you know, but probably you've heard that. Even today, I know of my friends with four generations of a family that live together in the same house. It's that strong. Flip side, there is no palliative care, or let's say the palliative care for cancer is negligible because parents live with their children, children care for their parents, parents care for their children. There are a lot of cases where family doesn't understand what the patient is going through. People outside the family don't understand what the family is going through. And when things get really bad, they don't know where to go because there are no hospices or palliative care centers in India. Cancer is a full body disease, and beyond the patient, it is a family disease. Not everyone dies, but everyone suffers. So, getting a doctor who understands all aspects of how cancer is impacting the patient and the family, it's nearly impossible. And if you don't have doctors around you, you just can't find the right person.
Hi, I'm Irene Lau here. I'm from Malaysia. Currently, now I'm residing in Subang Jaya. In Malaysia, we don't have a specific oncologist who is specialized in ovarian cancer. It's different, I think, when you have a specific oncologist who really knows the symptoms and uh, how to focus and make the line to treat the ovarian cancer. In Malaysia, we still need a lot more uh, to shout out to the public about this. So that's why being having a study, the ovarian cancer, patient study, that is a very good thing to make to make the awareness among the doctors as well, the oncologists.
So our thanks go to those women and the nearly 2,500 women who took part in the study. And you may be wondering for you what advocacy means for you. If you get the opportunity to take part in work like this in any form, please do. Think about what's important to you and talk to your clinicians about what's important to you. That's your self-advocacy, if you like. I'm going to whiz through some of the top line results. We are still in the process of analysing the wealth of data. We are presenting at the IGCS conference on Thursday morning at 8 o'clock. So the doctors will get to see the results too. So the average age of the women involved in the study was 51 years old. So often you're told that ovarian cancer is an older woman's disease. It's not. These are women who are economically active, they're looking after their families. It really does impact on society. And one of the other pieces of work that the coalition is doing is on the socio-economic burden of ovarian cancer. So looking at the impact on countries and economies of women who are diagnosed with ovarian cancer, not just the cost of their treatment. Most of them, 82%, had an epithelial form of the disease. There are many types of ovarian cancer. High-grade serous is generally the most common, and that's the same in our study. Overall, it was about 44%, but there were lots of women who never actually got to find out what their type of ovarian cancer was, possibly due to pathology issues. If you don't know the specific type of the ovarian cancer a woman has, you can't treat it most effectively. Stage 3 and stage 4, the women, 60% were in that stage. When you look at the high-grade serous only, it was higher. It was 79% diagnosed with that stage of disease. Most women had symptoms regardless of the type or stage of their disease. As you know, ovarian cancer is not a silent killer. Don't let anybody tell you there are no symptoms until late stage. So yeah, 94% had symptoms, and in some of our countries that was 100%. And we've got lots of detail on this. I'll whiz through some of the more complicated graphs, but basically this was showing the variation between countries. So all these different bars are different countries. The colours are associated with the Human Development Index, but basically it's showing the variation between countries. So countries like India do have a very high proportion of women who have high-grade serous. There are other countries where you get larger proportions of women with mucinous ovarian cancer or germline tumours. So it is important. We looked at the data on stage of diagnosis for those women with high-grade serous, and that group of plots on the right, you can see the colours vary. So there are some countries where almost all women are diagnosed late stage. There are countries there where high-grade serous, which is typically diagnosed late, is being diagnosed early. So why is that? These give us the clues into what's happening that we can look and learn from each other. A little bit on the demographics, picking up on some of the themes you've heard today. You know, 1 in 6 women roughly take 5 or more hours to get to the hospital for their treatment. We have stories of women, you know, sleeping on the floor in the waiting area in the hospital so that they can be there for their treatment the next morning. Unusually for this type of survey, we have nearly 40% of women reporting that their family income was below average for their country. It's about what's important to them. And just over 10% had no formal education at all. So it's quite unusual in this type of work to get that representation into a study. We asked about family history. Again, this varies by country, as does knowledge about your family history. So overall, we had about 7% of the women had a relative, close relative with ovarian cancer. Nearly 5% had one with ovarian and breast cancer, and then around 13% had a relative with breast cancer. This is important to look at. We looked at whether any genetic testing was being done. Almost none, basically, pre-diagnosis. Pre-diagnosis testing in families can help other women in their families be alert to the fact that ovarian cancer may be an issue for them, and it restricts opportunities for interventions along the way. Awareness. So over 2/3 of women did not know anything about ovarian cancer, and that did range by country quite significantly. Higher levels of awareness were associated with higher levels of HDI status, higher family income, and higher education levels. So for those doing education and awareness campaigns, the people in more distant communities, poorer communities, are really important to reach. Almost all of them sought help for symptoms, most commonly from a gynecologist or family doctor. So different countries, it's different for the approach. Most of the women, well, just under half of the women were quite concerned about their symptoms. Importantly, nearly 60% of the doctors were also concerned about the symptoms, which was a positive thing. And we looked into who was likely to visit a local healer. Time to diagnosis. For a quarter of the women, it takes 6 months or more from first experiencing their symptoms to get their diagnosis and start treatment. That varied between countries from 3 months to 11 months, so a lot of work to be done. The level of doctor concern is really important. If your doctor isn't taking your symptoms seriously, that will slow down your diagnosis time. It may sound quite basic to say, but to have the evidence is quite important. Increasing age is likely to mean you're slower to seek help, and lower family income, lower levels of awareness, and a greater distance from hospital also slow things down. So we asked about what were the delays and how they varied. And again, they varied by country. This is the whole story of this study. It's variation by country. Health system delays were the biggest. Then doctors misdiagnosing or doctor delays. Lower down was patient awareness and financial issues. We looked at treatment. So IGCS is very much focused on surgical aspects of gynecologic oncology. We looked at who had got the best level of surgery. Again, it differs by country. Again, it differs by country who receives drugs. We looked at post-diagnosis testing, which for ovarian cancer genetic testing can lead you into the world of PARP inhibitors, which have been quite successful, very successful, even game-changing. But you can see that just 17% of women had had a genetic test either pre or post-diagnosis. That was driven mainly by the countries in Latin America. And on the right-hand side, the little green bars are the women who actually received a PARP inhibitor. There was not one patient in our study in Africa who got that form of treatment. We looked at factors affecting quality of life. They vary depending on where you are. You might look at that list and see what's important to you, no matter which type of cancer you may have had or your family member may have had. But they vary by country. It's really important to know the women that you're serving as a doctor and looking after. And that's why we need patients to speak out, to get a service that is right for you. Looked at the impact of diagnosis and treatment on women, the side effects, the lasting side effects, whether they got help for them, emotional needs, largely driven by fear. I think we've seen it on another graph today. Fear of recurrence, fear of dying. And in this study in particular, the financial impact, with 45% saying their family finances had been affected greatly. And that meant overall, nearly a third had said their family income had fallen below that they needed to survive on. With families and extended families often picking up the burden of paying for very expensive diagnosis and treatments. Women's priorities for action. As with our 2018 study, development of a screening programme, we hope, it's not going to happen anytime soon. But for women in low and middle income countries, free access to diagnostic tests and treatments are crucial. Raising awareness of symptoms and reducing those delays in diagnosis. So it gives us a focus for action. Many opportunities for new research, for collaborations. Those variations highlight local and regional and global opportunities. We're hoping to see quite a few academic papers come out about this, and you'll see us doing more campaigning work on it as well. In conclusion, patient experience data can provide a nuanced, culturally sensitive and resource location appropriate response, that's a big mouthful, to deal with the challenges faced by women with ovarian cancer as the burden increases. The variability of those metrics by country and regional level reveal opportunities for progress and common calls, global calls to action. And I just want to leave you by saying, what might it mean for you? I hope you take away the importance of advocacy, whether it's standing up for yourself with a doctor, telling them what's important to you, whether it's participating in a survey like this, whether it's raising awareness of symptoms, whether it's taking part in a clinical trial. There are roles that you can play along this way, and you're part of that critical body of work really to inform the best possible treatments and interventions to improve your quality of life. Thank you very much.
Thank you, Frances. That was great and really brilliant work. The Every Woman study is such a remarkable initiative, and it is really clear to see the amount of effort involved from so many people all over the world.